Taking medications can improve health and quality of life, but for many older adults, taking too many medications can also create serious risks. In this Unison TV story, geriatric specialist Dr. Jacqueline McMillan explains what polypharmacy really means and how medications that once helped can sometimes begin causing problems. From falls and memory issues to dizziness, confusion, and dangerous side effects, the story explores how aging changes the way our bodies process medications and why regular medication reviews are so important.
Can you explain to people who might not know, just first of all, what is polypharmacy?
So polypharmacy, it has some different definitions. If you're reading like a research article, it might talk about taking more than 5 medications a day or more than 10 medications a day. But sometimes from a geriatric medicine perspective, we would think about taking medications that are unnecessary. So that could be that you're only taking 2 or 3 medications, but they're unnecessary. In contrast, someone could be taking more than 5 medications, but they're all appropriate and they're needed for the different conditions that the person has. And so although it's more than the definition, they're all appropriate medications and we wouldn't want to stop them if it's within that person's goals and their life expectancy.
Well, I guess how do we determine then what is necessary and what isn't?
That's a great question. My approach would be that if someone is experiencing side effects from a medication, or harms associated with medication, that would be an inappropriate medication. So for example, if somebody was experiencing falls or a change in their cognition, for example, their thinking or their memory, or if they were having gastrointestinal side effects that were limiting their ability to keep taking the medication, I would begin to wonder, is this a necessary medication for them? Or if they have so many medications that it's leading to problems with adherence to the medication, so they're just feeling so burdened by the pile of medications in front of them that they are starting to deprioritize on their own and selectively taking certain medications that are easier to swallow or sort of indiscriminately taking medications that I would worry, let's just prioritize the ones that are the most important for this person and avoid any side effects that they might be experiencing from medications.
How many side effects then are considered acceptable?
I would say it depends on the risk to the benefit that we're expecting. So if we're expecting that the benefit of this medication is significant, then it might be up to the patient to decide how much side effect they're willing to encounter. For example, if a medication has a side effect of dry mouth, but the potential benefit of that medication is high, that person might say, I'm willing to take this medication. I know the benefit is significant and I'm okay with dry mouth. But if the benefit of the medication is low and the side effect has a significant risk, such as feeling sedated or drowsy or not like your usual self in terms of your thinking, then that person, after we discuss, might say, this medication is not worth it to me, and the side effects are not worth the potential benefit.
How much of that decision is really just a personal desire versus a medical decision from the doctor? Like there might be some things, well, that person might have an opinion of what is a detrimental side effect versus a medical point of view saying, well, you need to tolerate a certain amount. How do you balance that?
I think that's one of the best things about geriatric medicine is that we aim to provide what we call person-centered care and holistic care because the different things that we're balancing as we age change and what we're hoping to achieve changes. So if someone's life expectancy is short in the realm of months to years, I might be less likely to recommend something that takes years to achieve benefit from. Or if the person tells me that they recognize that there's a risk of their cancer progressing, but they don't wish or cannot tolerate the side effects of chemotherapy, then that's a person or patient-centered decision to say that this person has sufficient information to make that decision. But I guess that's the key crux of it, is that our job is to provide the information that they need to make that decision.
Are there certain ailments that are more inclined to require more medications that people should just expect more medications?
There's certain medical conditions that often come with a whole constellation of medications. So, for example, cardiovascular disease, which can be broadly defined as risks for stroke or heart attack, those often require several medications. And so that's a situation where somebody might require a baby aspirin, a blood pressure medication, a cholesterol medication, and it can quickly accumulate to them taking more than 5 medications, but they're all indicated for that one condition. So they've had a heart attack and now all of a sudden they've left hospital on 5 to 10 new medications that they weren't on before the heart attack.
How about things like Parkinson's? I just know from a personal experience with a friend who has that. There's a slew of medications for that, and some which had some significant side effects.
You're right. And so the other thing that you bring up is the frequency of medication. So sometimes someone can have Parkinson's and they're only taking one medication class. So they might be taking Sinemet. It's just one medication, but it requires such frequent dosing that they might be taking it 4 or 5 times a day. And so that makes it automatically more complicated. And so because of how long drugs can remain active in our body, that determines how often we need to dose them. And so some drugs that last longer in the body, we can dose them just once a day. But other medications, if their effects wear off within hours, then we have to ask the patient, can you take it again at noon? Can you take it again at dinner? And so that can become very complicated. And in Parkinson's, that's the case with Sinemet in particular. It requires very regular dosing.
Are there suggestions you could offer patients who may have, memory issues or things that coincide with that would be difficult to take those medications at X hours?
That's a really common challenge that we experience with older adults in geriatrics. And sometimes it can be as simple as reminders on the phone so alarms on the phone. And sometimes that's not sufficient. Sometimes there are ways that the pharmacy can dispense medications that are called blister packs. And so the pharmacy will actually create it's the blister pack that you take home with you. And so you pop out the medications that you need for breakfast, noon, dinner, and bedtime. And then it can be a visual trigger that you've missed a morning medication or you've missed a noon medication. And another alternative is using a dosette. And you can buy these from a pharmacy and you can allot the medications that you're meant to take. And then it's again a visual trigger if you have missed a medication.
Sorry, what is that?
It's called a dosette. And so it's like often a plastic container with different attached vials, and you allot the medications into each section, and then you can have a visual indicator if you've missed taking a particular medication. And then home care can also provide assistance to individuals and come into their home and help remind them to take their medications if other mechanisms have not worked and we're worried about people continuing to forget their medications, then home care can come in and help remind them.
And is that something that's covered to have home care come in and provide the medications?
It is, and it can be a really efficient way to help people remember to take their medications. And I do have some patients that are hesitant to have someone come into their home, but I often remind them it's not usually a long visit. It's the healthcare provider can come in just for a few minutes, help you get your medications out, take your medications, and then they can go.
Are we seeing more cases of polypharmacy as I guess medicine progresses?
I would say yes, and I think part of that is that the population is aging, and so as we age, we often develop more medical conditions, whether it's diabetes or cardiovascular disease, high blood pressure, and then each of those conditions in itself requires more medication. So as people age, there's more comorbidity, and also with advances in medical treatment, we're finding new things that are really good for certain conditions. And so it might mean that what we used to treat with 2 or 3 medications a few years ago, we now know this 4th medication actually adds additional benefit. And so that's adding complexity to people's medication regimens.
Um, I guess what are some of the biggest risks? You touched on that briefly, but what are some of the things we should be looking out for?
So some of the things that are associated with polypharmacy include adverse drug reactions, and that's just a fancy way of saying it's an unanticipated harm due to a medication at a usual dose. So it's not due to an overdose or toxicity. It's just an unanticipated harm that can occur. And in older adults, that can occur because of the changes in our metabolism as we age. So we may not metabolize drugs as efficiently or excrete them as efficiently. It can be due to changes in the amount of water or fat content in our bodies. So those adverse drug reactions are a potential harm of polypharmacy. And then there's other similarly concerning outcomes that can happen, such as hospitalizations, falls, and some of those falls can lead to injuries, such as head injuries or hip fractures. They can lead to things like changes in thinking or cognition, where someone might feel a bit more confused or slowed down than before.
What kind of drugs cause that?
Often there are certain medications that are known to be what we call centrally acting, so they have an effect on the brain. And sometimes that's because they're interfering with one of the chemical messengers in the brain that we rely on for memory and thinking. And so then if we interact or interfere with that chemical that chemical reactant in the brain, that can impact learning and memory. There are other medications that by their intention make us drowsy. So sleeping medications, that's sort of the goal, is to help us sleep. But then in an older adult, the drug may still be around in the body the next morning, and then we wake up feeling a bit more confused or drowsy than usual.
Are there some that we shouldn't be driving with while we're on these?
Things that I would think about are anything that's new to a patient or a person that has a centrally acting effect, such as opioids. That would be probably the main one, or any escalation in dose of a certain medication that's centrally acting. So the main ones of concern would be things like opioids.
Okay. And how often should a person have their medications reviewed?
My biased perspective is when every time I see a patient, I review their medications because I want to ensure that any new medications have a good reason that they've been started, and any medication that's been stopped, there's a good reason it's been stopped. More broadly speaking, if you were not seeing a geriatrician, you're just seeing your general healthcare provider, it would probably be prudent to do that yearly. Or if there's a change in status. So for example, if you've had a hospitalization or a significant medical change, such as a stroke or a new diagnosis that has changed your personal goals or your personal life expectancy, that should trigger a review of the necessity of all of your medications. Or a move. So for example, if someone's moving into a long-term care facility, the necessity of all the medications should be reviewed.
And in terms of stopping medications, is that something, how do you decide if a patient can actually stop a medication?
I often approach it after discussion with the patient. So usually either they have come to me with concerns that they're experiencing burden from having to take too many medications, or I'm observing a potential harm, such as I'm seeing them for falls, and then I look at their medication list and think there's meds here that could be contributing to these falls. So the approach to de-prescribing is usually in a conversation with the patient. I try to prioritize their medical comorbidities with the most high benefit medications, and then use a benefit risk analysis. So if certain medications have a very high potential benefit, I help to communicate that to the patient, that prioritization. And then if there's medications that are known to be particularly harmful, those ones would be more of a priority for de-prescribing. So certain medication classes do come with increased risk of falls and cognitive decline or confusion. I would prioritize those for de-prescribing. But I always use the approach of going slowly. So tapering a medication and not discontinuing it abruptly, but rather going slowly, and then frequent follow-up with the person to ensure that they're not having any harms of de-prescribing, just to ensure that they're tolerating it and there's not a risk of side effects from the discontinuation process.
You mentioned going slowly. Let's say a person was on an antidepressant and they were feeling pretty good. Is the goal, should their goal to be to get off of it, or if they're not having side effects, to stay on said medication?
That's a great question because occasionally, if someone has a history of more complicated episodes with depression, that might be someone that should indeed stay on that medication more long term. And so more complicated experiences may include recurrent episodes of depression or hospitalizations due to depression. Those would be individuals that I would maybe encourage them that it's not a goal to actually de-prescribe that medication. And so that might require some input from a psychiatrist. In someone who has maybe one episode of depression that was more than a decade ago, and it was not significantly severe or requiring hospitalization, that might be someone that it would be a reasonable thing to de-prescribe over several weeks or months, and then monitor them very regularly, especially with each dose reduction, just to ensure there's no reintroduction of their symptoms.
And can the same be said for things like cholesterol medication, which someone may be on for life? Is there any reason for them to go off a medication like that?
Those ones are interesting too, because certain medications, we have more evidence about what their time to benefit is. And what I mean when I refer to that is how long does that person need to take a medication to see the benefit of the medication? So a cholesterol medication has a particular time to benefit. And if that person I expect to live longer than that time to benefit, I would encourage them to stay on it because their risk of a cardiac event or a stroke likely is never going to go back to zero. So for the remainder of their life, they are going to benefit from that cholesterol medication. But if they get to a point in their life that their longevity is being measured in months, it might be a time to say the ongoing benefit of you taking this medication is going to take longer than how long we are expecting that person to live. And that might be a time that you say we can de-prescribe this medication.
And are there any words of encouragement, I guess, you could offer to older adults who are seeing that list of pills grow longer and longer, and their daily routine is being upset because, oh, that alarm's going off again at 2, at 6, at whenever to have those pills, and they said, I don't want to take this anymore. Any kind of words of advice you could offer to that person?
I would encourage them to speak with their doctor, and it would be the role of the doctor to help go through them medical condition by medical condition and determine which ones are truly indicated, and then to communicate, why is it indicated? Am I hoping that this will make you feel better, or am I hoping that this will make you live longer? Because those are two very different things. The other thing is, I would say most physicians are open to having this conversation, and I don't think patients or individuals should ever feel hesitant to say, I've been skipping medications because there's too many. I'd rather hear that and then have a more realistic plan for their medications than to not know that they're struggling, because then I can help you to prioritize to say these ones are actually the most important, these 3 are the most important, and they can feed back and say, I don't mind taking all 5 in the morning, but when you interrupt me midday and I'm out with my family and I don't want to stop my meal to have to make medication, that midday one is really troublesome, or I tend to forget that one because I'm usually out. Those are very valuable conversations to me because there's often a lot of flexibility and creativity that can be used to help to minimize that burden. And sometimes there's prescribing sort of inertia that can happen where medications get refilled that are no longer needed anymore. And so they might be started with the intention of carrying on for 1 year. And then with inertia, somebody just keeps refilling them and they're not actually needed anymore. And so by bringing that to the attention of the doctor, then they can say, oh, you don't need that. So we can quickly reduce your medication list by 1 or 2 or a few here.
That's an excellent point. Make sure you're just always on top of that and always be asking questions. And really good point you brought up there. And one last thing for you, and say someone does miss that they're out golfing or whatever, they miss that 4 o'clock one. Should they make up for that, or how, or does it depend on the medication if you miss that?
Yeah, I would say most often I would just take it once you realize, but I would be cautious about doubling up on medications. So if you don't realize that you haven't taken it till the next day, I probably would avoid taking a double, taking 2 pills on the same day. But most medications you could safely, if you realized when you get home that evening, just take it then. The other one that you might want to be cautious with are ones that we take multiple times in a day. It's in the same vein, I would say don't double up. Like if you were meant to take it at noon and then you're meant to take it again at dinner, don't take both at dinner.
Okay, that's what we don't want to be doubling up on there.
Mhm.
Excellent. Anything else that I might have missed in this discussion?
I don't think so. I think one of the key things that is actually a really positive is that reviewing medications
Mhm.
helps the patients understand their conditions. And I think it's very empowering because sometimes these conversations help to motivate to stay on medications we know are helpful. And I love de-prescribing. It's one of the best parts of my job is de-prescribing because sometimes there's adverse effects that have been going on that just haven't been recognized for what they are, or we can get into prescribing cascades where the side effect of one medication is actually treated like a new symptom, and then another medication is started to treat this new symptom, but it was actually a medication side effect. It's not a new condition at all. So I find it really rewarding, and I'd say most physicians would be very happy to have these conversations.
Wonderful points, and thank you so much for the research you do and the time you've shared with us today. I really appreciate it.
Well, thank you. I really appreciate your interest in this.